Welcome to this last video in the series on patient autonomy. And in this last video, we're going to take the perspective of taking a look at outside influences on the physician-patient relationship, in particular in relationship to the three medications that we'd look at within this unit. So to start out with, what is the ideal physician-patient relationship? Ideally, under the best of circumstances, a patient is going to be able to go to a doctor or go to within their normal practice or a doctor within a hospital setting and come up with an individualized treatment plan based on their specific needs and based on their specific conditions. And so kind of in its most traditional sense, and this is going back potentially hundreds of years, the idea is that a patient would go to a physician, go to a specialist. They would often have access to their own kind of set of medicinal products. In this case, we're looking at a medicine box that is roughly analogous to the medicine bags that you would see of the Native American Indians, where you'd have the ingredients needed to make a medication, to make in essence, a treatment. And so the doctor would, interview the patient, do a diagnosis, collect their history, determine what they need, and then mix the ingredients together and give them some type of a potion or elixir that would treat their condition to ideally improve whatever it is that they came to see the doctor about. Now, as medications became more complicated, as the number of ingredients became more onerous, more difficult to pack into a kind of a small medicine box or medicine bag, we saw the advent of pharmacies. And so that mobile pharmacy, a collection of vials and containers with the raw ingredients became more of a stable location. In this case, we've got an apothecary kind of along the wall. You can see lots of different bottles and containers holding the raw materials. And so basically the idea with this is that the doctor would work with the patient to come up with an individualized treatment plan, but then they would write something. In the case of modern medicine right now, they would write a prescription that the patient would take to the pharmacist, and the pharmacist would fill that prescription based on the needs. Now recognize that this model is kind of an American model. Other places in the world, patients can go to a pharmacist or a chemist directly, direct access, explain what they need, and in many cases they're able to get the medication directly from the pharmacist without having to resort to going to see a physician. Now again, with further complications, we can see the development of drug companies where we've got essentially an organization or a group of individuals or a company that are going to specialize in the production of medicinal products. In this case, we've got a slide kind of representing the top 10 pharmaceutical manufacturers within the United States. Now, keep in mind that, in this system, we're looking at, maybe 100 years ago, 120 years ago, 150 years ago within the United States, we would have these companies that would be producing medicinal products, but there was really no indication as to whether or not we'd be dealing with a true beneficial prescription medication, illustrated here within the RX, the prescription bottle, or if we're getting some type of elixir with kind of an unproven claim. And I'm just using this to represent the snake oil that would be curing all. That was very prominent. If we take a look at the traveling medicine man going from town to town with a cart and miracle elixirs that they would provide. And in many cases, some of these medications, some would be very, very beneficial in the terms of this prescription drug here. Others would be less beneficial, potentially fraudulent, where patients would pay, hard money to get access to something that would have no benefit. But in an extreme, sometimes these snake oils, sometimes these medications that were put together by less than ethical companies could be actually harmful to the patients. And so at that point, we saw in the United States the legislature get involved. The government got involved. They passed some rules as to, what would determine, kind of safe and effective medications. Ideally, originally, this was just to have a safe medication that wasn't poisoning patients, and so the creation of, regulatory agencies, and we're kind of illustrating this with the Food and Drug Administration, which is what we have now within the United States. But it's gone through, some various permutations. Early on, it was basically there to kind of ensure the purity of the products and make sure there were no poisons included. But the FDA and their ancestor kind of organizations within the government would basically serve, as this traffic cop or stop sign, if you want to think about a stoplight here as we're illustrating here, that would allow through, beneficial medications, but eliminate the snake oils, eliminate those potentially harmful agents. And so they act as ideally a neutral party in between the manufacturers of the drugs and access of the drug to the patient. Again, with some complications with the system of medicine that we currently have, what we see now is that the patient often is not the one that's actually paying for the medication. They may pay a relatively small copay, but we are seeing that either Medicare or an insurance coverage is actually paying for the medication. And so the pharmacist is buying it from the drug company, but they're actually being reimbursed for the medications that are provided to the patients by the patient's insurance coverage or Medicare coverage. But what we can see is that these insurance companies, the Medicare as a government insurance plan in essence, has limited funds available to it. You can't cover everything. You can't give access to everything. And so in many cases, we can see that both Medicare and the insurance companies are going with a limited formulary. They're going with a set of approved medications in which the patient can get. And so what we can see is that for some medications that the patient might need, they need pre-approval. And so the doctor's office has to reach out to the insurance company to convince the insurance company that this is a beneficial product that is needed by the patient for their treatment of their specific condition. But you can see that this very simple relationship between the doctor and the patient becomes even more complicated when we start dropping in the regulatory agencies, the payers, these third-party payers. We're taking a look at Medicare and the insurance coverage, all kind of getting involved in this process. Now in 2022, we're seeing that's getting even more complicated with the desire to get medications for the treatment of COVID-19. And we've got an intervention of court systems that are going through, and in some cases, taking a look at the ivermectin kind of example that we had earlier on within this set of videos. You've got patients going to, in essence, sue hospital systems in the courts to get access to ivermectin or get access to the medication that they want. And in some cases, the courts are saying that the hospitals have to provide access to it, or at least have to provide the ability of the patient to get it, even if the hospital isn't providing that directly. In addition to that, we've got the legislature over here, and these are proposed laws at this stage in late 2021, early 2022, basically saying that ivermectin or other medications have to be available to the patient. But in both these cases, you've got the courts and laws being written by legislatures, which in many cases aren't doctors. That are intervening on that doctor decision that's hopefully an informed decision made with the patient to determine their best medication. And the question is, should these outside parties be dictating what the not sure what happened there. If these outside parties should be intervening in that doctor-patient relationship and directing what types of medication should be available, even to the point of recommending the use of off-label medications So not even using, what it's FDA approved for, but using it for an unapproved use, a use that hasn't been proven or at least licensed by the Food and Drug Administration. So kind of bypassing this little stoplight that the Food and Drug Administration is acting as. So this gives rise to our ethical dilemma with this, and kind of looking at this within this entire unit. How do we ensure equitable access to safe and effective medications? And then take a look at this from a variety of perspectives. How do we reach a decision? How do we reach a decision as to what medication the patient is going to get? When we have to do a benefit versus risk analysis, but that benefit versus risk analysis is conducted with very, very different goals. If we take a look at the goals of a patient, what the patient wants is going to be to be better. They want to treat the condition that they've got, treat the disease that they may have, or treat the condition they have with a medication that's going to allow them to have a high quality of life. They still, again, the patient with limited resources wants it to be an effective treatment as at a reasonable cost. And so basically, in many cases, this is going to be dependent upon their prescription coverage. If it's within the formulary that their prescription plan provides, they can usually get it with a copay. They'll pay, a small out-of-pocket expense, and then the bulk of the prescription cost is going to be coming from that third-party payer, coming from the insurance company or coming from Medicare. However, when that's not covered, what does that mean? What does that mean for a patient that wants to get access to that? What is the perspective of a physician? The physician is ideally looking out in the best interests of the patient, and they want to work with the patient in an informed manner to determine the most effective treatment based on that individual patient's specific needs, to come up with an individualized treatment plan based on the patient in front of them, not a generic patient, not on the bulk of patients that would be out there, but specifically what that patient sitting in front of the doctor needs at that period of time. And that may be a little bit different from what the patient is wanting. And we're seeing that occurring where patients are asking for things that the physician may not necessarily feel is right for them, for their condition, for their situation at that time. We start to add in things like drug companies. The drug companies are our company. They want to sustainably produce their medications, provide it to the patients, to provide it to their clientele. And so ideally, they want to be able to develop medications that patients are going to want, ideally medications that are going to be effective. But they still got to be able to provide that and make a profit, or at least be sustainable. They're not going to produce these medications and then go out of business because of that. You don't want a company to go broke, because if they go broke, they're not going to be able to provide the medications going forward. The Food and Drug Administration, we put that in, as a safeguard. They're there to maximize the benefits for our patients. Make sure that what they're getting is going to be beneficial. To protect the patient from a fraudulent claim, the snake oil that cures all. You want to be able to get the patients what they need and minimize the harm. And so another aspect of that is the quality assurance role of the Food and Drug Administration, where they go through and monitor the production of medications to ensure that they're quality products, that there are no contaminations that could potentially cause detrimental effects to the patients that are taking them. Add in the payers, the third-party insurance companies, add in Medicare. Again, their goal is that they want to provide access to safe and effective medications, but again, they're going to be doing what is generally referred to as reasonable and necessary for the treatment of an illness or injury. And so they're going to be looking for a cost-effective medication that provides the maximum benefit within a limited amount of funds. And so what you can see is that in many cases, insurance companies, Medicare, are going to come up with a list of approved medications for specific uses. And so what that means within that formulary, they've got things that are approved. And if you want something that is outside of that approval, you've got to request it. And in many cases, it won't be covered. In some cases, taking a medication, for a reason other than what it's been approved for will require pre-approval. And so the Medicare or the insurance company will reach out to the doctor's office to find out why are they prescribing this medication. Because they want to make sure that what they're providing is going to be an effective medication that's going to be beneficial for that patient. Otherwise, they're going to be using funds to support that use that isn't going to make the patient better, and those funds then could be used elsewhere, hopefully, to improve the medical situation. Take a look at this from the government perspective, whether we're talking about the legislature or the judicial courts. Lots of evidence saying that there is an enhanced public health, the enhancement of public health, the enhancement of the quality of health available within the population minimizes long-term costs associated with healthcare, minimizes long-term costs associated with disability. And so you could argue that the role of the government in overseeing medications is to advance a public good, because access to good quality, safe, and effective medications is beneficial for society. It's beneficial for the common good. And then we drop in the judicial system, the court systems. They're there, again, as a form of arbiter, if we want to think about it that way. And they're there to make sure that there's fair and equitable access to health care within the law. And so that individuals are not being discriminated against or prevented from getting access to what it is that they need within their insurance plan or within their coverage details. But as you can see, each one of these different parties involved in that decision making as to what the patient is going to be able to get has a slightly different goal involved. And because of that, they may come up with slightly different decisions as to whether or not they will provide access to that medication for the patient. Will the insurance company cover the medication that's needed? Is this a medication that is actually available and can be purchased, or is it something that is prohibited? And so we got all of these different questions that we can think about. How do we ensure equitable access to safe and effective medications? Within the unit where we're taking a look at, does it matter if the status of the medication is different? We got the Autonomy. We've got the the monoclonal antibody treatment for Alzheimer's disease that would ideally minimize the formation of those amyloid plaques, potentially to offset or delay the onset of degeneration of the nerve cells, to put off the loss of the cognitive impairment that develops with dementia. Hopefully, we'd be able to do that. It's approved by the Food and Drug Administration, but now, spring 2022, we're seeing that there is going to be limited coverage potentially by Medicare and by the insurance companies that base their coverage plans on what Medicare is going to be covered. For medical cannabis, we're looking at a product that is federally prohibited, but legal within state medical programs. Many cases, many of the states, it's still not available to individuals that are not using it for medicinal purposes. But what does it mean if it's federally prohibited? Ideally, if you're getting a medication within a state medical program, if you're getting medical cannabis, you can't take that when you're traveling. You're not supposed to cross state lines with that. But what does that mean if you need that medication to treat your condition? Ivermectin, patients are asking for an unproven off-label use of this medication that is FDA approved and very effective for the treatment of roundworm parasites. But what does it mean, and how much emphasis should be given to determine whether or not a patient could kind of overrule a doctor to get an off-label use of something that the physician may or may not feel is going to be beneficial for that patient. And so lots of different questions that we can ask in terms of ensuring equitable access to safe and effective medications. What does it mean if the insurance company won't cover it? For a patient with limited economic means, limited financial resources, the insurance company won't cover it, they're not going to get it. What does it mean to a patient with more financial resources? They may be able to pay out of pocket for a medication that is not being covered by their insurance. But then all of a sudden, it's no longer equitable access because it's different based on the patient's circumstances. And so lots of different things that we can think about regarding this equitable access to safe and effective medications. A couple of references associated with this. So hopefully within the discussion within the course, post within your discussion group, have a discussion about what it means and how do we ensure equitable access to safe and effective medications. Thank you and have a great week.